Hello and welcome. Today we're delving into the details of a rare but serious inherited condition called homozygous familial hypercholesterolemia, or HoFH. This is a severe form of familial hypercholesterolemia that leads to extremely high levels of cholesterol in the blood from a very young age, significantly increasing the risk of early heart disease. HoFH is primarily caused by genetic mutations affecting the body's ability to remove low-density lipoprotein, or LDL, cholesterol from the blood. Specifically, it almost always involves inheriting two defective copies of a gene, typically the LDLR gene. This gene provides the instructions for making the LDL receptor, a protein on the surface of liver cells. These receptors bind to LDL cholesterol, allowing it to be taken up by the liver for breakdown and removal from the bloodstream. Other rare genetic mutations, like mutations in the ApoB or PCSK9 genes, can sometimes cause HoFH, but these are less common. The pathophysiology of HoFH centers around the profound deficiency in functional LDL receptors. Without enough functional receptors, LDL cholesterol accumulates in the blood. These extremely high levels of LDL cholesterol overwhelm the body's normal processes for handling fats. Over time, the excess LDL cholesterol begins to deposit in the walls of arteries, forming plaques. These plaques narrow the arteries, a process called atherosclerosis, restricting blood flow and leading to a greater risk of blood clots, heart attacks, and strokes. In some cases, cholesterol can also deposit in other tissues, such as tendons and skin, forming xanthomas. Homozygous familial hypercholesterolemia is a rare condition. It is estimated to affect about 1 in a million people worldwide. It's important to distinguish it from heterozygous familial hypercholesterolemia, which is much more common, affecting around 1 in 200 to 500 people. Due to its rarity, HoFH is often underdiagnosed or misdiagnosed, leading to delayed treatment and poorer outcomes. The signs and symptoms of HoFH are often apparent in childhood. One of the most noticeable signs are cutaneous xanthomas, which are yellowish cholesterol deposits on the skin, particularly around the elbows, knees, and tendons, especially the Achilles tendon. Arcus cornea, a grayish-white ring around the cornea of the eye, can also develop early in life. More seriously, individuals with HoFH may experience chest pain or angina at a young age, even in their teens or 20s, due to the development of coronary artery disease. Aortic stenosis, narrowing of the aortic valve, is another serious consequence that can occur. Diagnosis of HoFH typically involves a combination of clinical evaluation, family history, and laboratory testing. A key indicator is a dramatically elevated LDL cholesterol level, often exceeding 400 mg/dL, even without dietary indiscretions. Genetic testing to identify mutations in the LDLR, ApoB, or PCSK9 genes is crucial to confirm the diagnosis and differentiate HoFH from other causes of severe hypercholesterolemia. It's also important to screen family members, particularly first-degree relatives, to identify individuals who may be affected. While there aren't distinct types of HoFH in the same way as some other diseases, the severity of the condition can vary depending on the specific genetic mutations involved. Some mutations result in a complete absence of functional LDL receptors, while others allow for some residual receptor activity. This variability can influence the age of onset of symptoms and the response to treatment. Treatment of HoFH is challenging and requires a multifaceted approach. Lifestyle modifications, such as a low-cholesterol diet and regular exercise, are essential but often insufficient on their own. High-intensity statins, medications that block cholesterol production in the liver, are a cornerstone of treatment, but their effectiveness is limited in individuals with HoFH. Ezetimibe, which reduces cholesterol absorption in the intestine, is often added. PCSK9 inhibitors, which increase the number of available LDL receptors, can be helpful, but their efficacy varies. Apheresis, a procedure that throws LDL cholesterol directly from the blood, is often required to lower cholesterol levels significantly. In severe cases, liver transplantation may be considered to provide functional LDL receptors. Currently, HoFH can't be fully prevented, as it is a genetic condition. However, identifying individuals with familial hypercholesterolemia through family screening and genetic testing is crucial. Early diagnosis and aggressive management can significantly reduce the risk of cardiovascular events. Genetic counseling is important for families affected by HoFH to understand the inheritance pattern and make informed decisions about family planning. The prognosis for individuals with HoFH is significantly impacted by the timing and effectiveness of treatment. Without aggressive management, many individuals will experience premature heart disease and may not survive into adulthood. However, with early diagnosis, intensive treatment, and ongoing monitoring, it is possible to improve cardiovascular outcomes and extend lifespan. Research is ongoing to develop new and more effective therapies, including gene therapies, that may offer the potential for a cure in the future. These emerging treatments aim to correct the underlying genetic defect and restore normal LDL receptor function, offering hope for a brighter future for individuals living with this challenging condition.